Hello again, everybody. We are doing kidney, ureter, and bladder today, okay? Now, if you haven't done so already, I want you to pause the tape and go do your preparation for kidney, ureter, bladder. There are some basic, easy structures that I want you to have a good grasp of to the point where you can visualize it in your mind before you listen to this lecture, okay? So the kidney, the ureter, connects the kidney to the bladder. The urethra will leave the bladder to the external environment. That's a basic anatomical structure of the kidney. The microscopic structure is the tough part. Okay, looking at the teeny tiny filtration system. So those are the two major anatomical things that we'll look at. Physiological, or the functional part of the kidney, is obviously going to be to create urine. Okay? In order to create urine, we need to have a certain blood pressure pushing blood into the kidney so we can filter that blood and form urine, okay? So blood pressure regulation is another thing that the kidney will do to maintain that blood pressure, okay? The kidney also creates a substance called erythropoietin. The kidney is constantly monitoring substances in the blood. So this is actually a perfect structure to help monitor the amount of red blood cells flowing through the body. If there are not enough red blood cells, not big enough, I'll zoom in on it. Erythropoietin, 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 is a hormone released from the kidney that stimulates the creation of more red blood cells. Now, the interesting thing is that athletes will use a laboratory-formed type of erythropoietin, and the whole logic behind that is they'll create more red blood cells, which will give them more oxygen, so they can be better at whatever sport it is that they're doing. Okay, so kidney now creates urine, helps with regulation of blood pressure, can release erythropoietin, which will stimulate the creation of red blood cells. Finally, it actually is the last step in converting cholesterol into vitamin D, okay? Vitamin D actually comes through very complex steps, biochemical steps of converting cholesterol into vitamin D. The kidney contributes to that. It's the last step in that creation. And as you know, vitamin D is very important in taking calcium from the intestines and putting it into the blood. So, very important physiological functions. A lot more organ than you think, I bet. Kidney anatomy. I'm going to zoom in on this. Maybe. There we go. Kidney anatomy. It is, a little refresher, retroperitoneal, which means that it is behind those serous membranes or that peritoneal cavity, retroperitoneal. Those serous membranes actually help to hold the kidney up, okay? It's like saran wrap surrounding the kidneys, pushing it back up against that abdominal wall in the back. There's also something called P-E-R-I, renal, R-E-N-A-L, fat. This perirenal fat also surrounds the kidney and holds it up. That's going to be a very important clinical thing that we'll talk about in just a minute. So perirenal fat. Those two things help to hold the kidneys up. You can see from this picture coming from the kidney going down to the bladder is the ureter. There's a right and a left ureter. They pass right over the common iliac artery and vein, okay? And then go to the bottom side of the bladder. You could see if the kidney were to drop. So if we were to either tear those serous membranes, the more likely what would happen is we would lose that perirenal fat. The kidney could drop. Now, if the kidney drops, the ureter is now not held tight or taut. It can bend and kink. Urine can back up into the kidney and cause this thing called hydronephrosis. That's on the next slide, if you want to look at the next slide. hydronephrosis, okay? That's going to be a buildup of fluid in the kidney. It's going to stretch the kidney and put stress on the kidney until it's not functional anymore. Excuse me. The red structure, dig deep. What is that? That is the main arterial supply of the body. That is the aorta. To the right of it, or our left, is the inferior vena cava. The aorta is an artery. The inferior vena cava is a vein. Okay. Now you can see the placement. That's how it is in all of us. The aorta is on the left. The inferior vena cava is on the right. So if I were to ask you which renal vein is longer, okay, you would say the left, because you can see the inferior vena cava is to the right of the body. The right renal artery would be longer, okay, because the aorta is to the left side of the body. Clinically, that's important. They tell pregnant women not to lay on their right sides because they can compress the inferior vena cava. Now, the inferior vena cava is a lot flimsier than the aorta, and it also has a much lower pressure of blood, okay? When blood comes out of the heart, it's coming out fast and hard. It's going to push its way through that aorta, whether you're compressing it or not. The inferior vena cava is going to be more easily compressed. So as a woman gets bigger, her stomach gets bigger, she lays on her right side, it can actually push on that inferior vena cava, and it can prevent blood from getting back to the heart, okay? Of course, it wouldn't cut off all the blood supply, but it could cause a little bit of a backflow that would back up into the venous system, and it could cause some complications. Okay, on top of the kidneys are the adrenal glands that we talked about in endocrine. And are those actually part of the kidney? No, they're not. They're part of the endocrine system. They just happen to sit on top of the kidney, okay? All right. You can see there's a coronal, or I'm sorry, transverse or horizontal view. Those are the kidneys towards the back. You can see the vertebra. We're looking down inside their stomach. You can see that they're retroperitoneal. Okay, they're behind that peritoneal cavity. I think that's a great picture. And it really helps to show us how the abdominal regions divide into separate compartments. So you have the peritoneal cavity, you have the retroperitoneal cavity. Okay, so we went through these. The renal artery is longer on the right. The renal vein is longer on the left. The adrenal glands sit on top of the kidney, but are they part of the kidney? Nope. Okay, if we lose too much fat, that perirenal fat, we talked about this, the kidney can drop. Now the actual pathology, or the name for that pathology, would be ptosis. You drop the P, you don't say ptosis, it's ptosis, okay? And that's a dropping of the kidney that can also happen in the eye. If somebody's had a stroke, excuse me, and their eye droops, that's called ptosis as well. Ptosis of the kidney would cause the ureters to kink, fluid to back up into the kidneys. You could get hydronephrosis. Okay. Now we're looking at a frontal or a coronal view of the kidneys. Okay. That outer rim is the cortex. And you can see there are pyramid-like structures on the inside. There's 1, 2, 3, 4, 5, 6, 7 of them. Okay, pyramid shaped with the points pointing in towards the center. That whole area is the medulla. Okay, so we've got the renal cortex and the renal medulla. The renal medulla has those triangular shaped structures, which are the pyramids. Okay. And then towards the right side of that, you may be able to see this on this picture. You may need to get your book out. Either way is fine. You could see that the pyramids then dump into a space. So that solid part of the kidney then gives way to open spaces, which are towards the inside of the kidney. Those spaces will collect urine. The cortex and the medulla are what filter urine. Okay, so what filter urine is, blood is filtered, starts to create urine. Urine will then start to dump in those spaces to go into the ureter. Okay, so it's a general gist of the whole thing. You can also see the renal artery and the renal vein. Excuse me, the renal artery brings blood in to be filtered. Now, it just doesn't dump it into the medial aspect of the kidney. It'll actually form smaller and smaller arteries, and the smallest ones are on the outside of the cortex. Okay, you can see that. They divide down if you take a closer look. Filtration happens, and then blood is sent back through the blue structures, which are the veins. Okay, starts at teeny tiny veins that go bigger and bigger until it gets to the renal vein. And that's what brings blood into the kidney to be filtered and takes blood out after it has been filtered. Okay, then it's filtered through the cortex and different structures in the medulla, which we'll talk about very soon. Whatever is filtered and creates urine goes into those spaces, okay? Whatever isn't goes back out by the renal vein. So the outsides of cortex, we established that. Those triangular shaped structures are pyramids, okay? The pyramids come to a point. Those points dump into what are called minor calyces. Okay, minor calyces, or a minor calyx is singular, are spaces that gather up that urine, okay, and send it to the major calyx or calyces. Okay, the major calyces then send urine to the renal pelvis, and I mean this is essentially one big space, but of course we have different names for the spaces, right? So a minor calyx is right near the point of the pyramid. Two of those minor calyces dump into a major calyx. Right as it starts to enter the ureter, it is now the renal pelvis, okay? Now, you could see all the different names of the different arteries. You don't need to know them. You need to know renal artery is going to bring blood into the kidney, renal vein takes it out. There are some other minor ones, but we need to figure out the microscopic structures before I explain those to you. The major structures that you need to know, vascularly speaking, are renal artery and vein, okay? Infections, pyelitis. So urine should be sterile, okay? Urine in this entire internal environment of the kidney, ureter, bladder, urethra should be sterile. If you bring in bacteria, okay, an example of what can happen is if a female wipes from back to front. If she brings any of the bacteria from the vagina or the anus into the urethra, it can bring bacteria into the urethra, into that sterile environment, cause infections. Now, the first step of this process would be a UTI, or urinary tract infection. Okay, that would be when bacteria gets into the bladder and causes an infection. Now, if that continues up, goes up the ureters and goes into the openings, those openings we just talked about, the pelvis and the major and the minor calyces, that is known as pyelitis. If that infection continues into the whole width of the kidney, including the solid part as well as those spaces, so it's moving out to the medulla and the cortex, that's pyelonephritis, excuse me. Okay, pyelonephritis. Okay, so pyelitis is just the openings, the pelvis and the calyces. Pyelonephritis is basically the whole kidney. And that could be from bacterial spread from the vagina or the anus into the sterile environment of the urethra. Okay. Nervous control. There's sympathetic and parasympathetic nervous control. We're not going to get much into this. I'll talk about it as needed as we get there, okay? Because they'll do different things at different points, but I need to explain some different structures to you first, okay? So sympathetic and parasympathetic. Nephron. Okay, this is the fun part. So I'm going to back this out, okay, and zoom it on in. We are going to talk about the different parts of the nephron. Okay, so we're basically going to cover the next two written slides along with the picture. So if you want to, you can look ahead a little bit. This is a big one. This is a tough one. So this is another one of those times that if you get to one little point that you don't understand something, shoot me an email, come to my office hours, okay? So the nephron, this picture that they have in your notes or in the book, excuse me, here's your kidney. What they're doing is taking this section and blowing it up. So we're looking at the microscopic structures on the inside of the kidney now, okay? We've got teeny tiny filtration systems in the kidney known as nephrons, okay? There are like 2 million in our kidney. We're gonna look at one of them. I draw it, I'm sorry, I've done this for years. I draw it the opposite way it is in your book. So if you look at the picture I draw and then look at your book picture, it's transposed. But I'm sorry, I've done it this way forever. My old brain doesn't work as well as it used to. Okay. So this filtration system is basically a series of tubes. Okay. I drew it the opposite way. We'll just move this over. Okay. Now, what happens in order to create urine, our first step is we need to filter blood. And we need to filter blood. So what happens is we bring blood in by the renal artery. Remember all those small arteries, divide, divide, divide. We send blood out to these teeny tiny arterioles, which are in the cortex of the kidney. Okay, so that's where we are right now. We're in the cortex of the kidney, looking at it with a microscope. So those arterioles divide, divide, get smaller and smaller until finally they're teeny tiny. They're going to bring blood into this beginning of this tubular system. Okay. At this point, this is where people get lost. So I want you to get this concept. At this point, blood is either put into the tube that we're looking at, this whole black tube, or blood is sent out and back into the bloodstream. Okay, so at this point, blood comes in, okay, it's either put into this tube or it's sent back out into the bloodstream. One step further, if blood is filtered and the fluid that comes out of that filtrate, or should say, stays in the tube all the way, it's eventually going to turn into urine. Okay, so if I continue this tube, one more step, and it stays in here, that's going to form urine. Okay, or blood could be sent out back to the bloodstream. That's one of the major concepts. It's either going to go back to the bloodstream or out the urine. That's our choices. Okay, it's not going to stay in the kidney. One or the other. Okay. So let's see how this happens. These blood vessels are called afferent, arterial. Okay. This one is called efferent. Sorry, arterial. If you can imagine that I have a big beach ball and I take surgical tubing and I put the surgical tubing magically inside the beach ball, okay? I hook up tubes to both ends of that surgical tubing, okay? The two ends come out of the beach ball. So you've got one end coming in, you've got surgical tubing twisting and turning inside that beach ball, and eventually the surgical tubing goes out. Can you visualize that? Okay? That's your blood flow going through this filtration system. You bring blood in, it goes through this surgical tubing inside this big beach ball, blood goes out. Let's draw that on here. Blood comes in. Here's the surgical tubing, okay? Trying to draw this as a tube, okay? If blood stays in the surgical tubing, it'll continue out. And where it's going is back to the bloodstream. Can you picture that? Okay. If we push blood in and substances leak out of that surgical tubing, they're now in the big beach ball. Okay? If blood goes into that surgical tubing and leaks out of the surgical tubing, it's now in the big beach ball. Okay? If we stick a hose on the bottom of that beach ball, that fluid is now going to leak down into that hose. Okay? And it starts to go into this tubular system. Okay? That's the first step of creating urine. We filter substances from this capillary, from the bloodstream. We put it into the big beach ball and we start to send it out through this tube. Okay? And along this tube, we're going to have various areas that will reabsorb substances, take it out of that tube and send it back to the bloodstream. I'll explain that to you in a little bit, how that happens. Okay? So along this tube, the body decides, man, we need more water. We're going to take it out of the tube and send it back to the bloodstream. Okay? So our choices are, we send blood in, blood stays in this capillary, goes right back to the bloodstream. That's choice number one. Choice number two is some of that blood or substances in the blood is filtered out of the tube, stays in the big beach ball, starts to get pushed into this tubular system, starting to create urine. Okay, whew, it's a big one. Okay, so if you don't understand that, get a hold of me. Get a hold of me. Okay, so the afferent arterial brings it in. This capillary network is known as the glomerulus. Okay, the glomerulus, Glomerulus, glomerulus. The glomerulus is going to be this tubing, okay, that's in the big beach ball that connects back out to the efferent arterial. The big beach ball is called Bowman's capsule. Bowman's capsule. Okay? So that big beach ball is Bowman's capsule. The whole thing is called the renal corpuscle. So the glomerulus and Bowman's capsule together form the renal corpuscle. Okay, so that's Bowman's capsule plus the glomerulus equals the renal corpuscle. That's the whole shebang. Okay, so that's a lot. Okay, that's a lot. Let me give you the names. I want you to pause for a second. Make sure you understand all this because I'm going to erase it because it's getting a little convoluted. We're going to talk about convolution in just a minute. Okay. I'm going to erase these structures that we've named so far. Or the names, I should say. Let me give you the names of all these tubes. Now, part of the tubular system is going to be in the cortex. Part of the tubular system is going to be in the medulla. Okay. Along the tubes, there are different names. This first part, if I were to tell you about my day, I got up. My husband would leave at 7 to go to work, and then I had to get the boys up. I had to get my son to preschool, and then I dropped my son off at preschool, and I go to Walmart. Then I go to Walmart, then I get home, then I get a shower. This is way too much information, right? It's twisty-turny. Who cares? You just want to hear that I got here today and I gave you a lecture, right? I'm just kidding. Although some of you probably do. Twisty-turny story is convoluted. It's a convoluted story. So twisty-turny. This part, this is on the next written slide, is called the proximal convoluted tubule. Okay, so proximal, meaning close to the origin or the renal corpuscle, proximal convoluted tubule. Okay, proximal convoluted tubule. It's going to be the twisty-turny first part of this tubular system. Okay, where it becomes straight, and there's different parts to this, but we're just going to learn the whole thing as the loop of Henle. Okay, the loop of Henle, that's going to be in the medulla. Now we have twisty-turny again, don't we? That's going to be distal convoluted tubule. Okay, distal convoluted tubule. The distal convoluted tubule then leads to what's called the collecting duct. Okay, so this straight part is called the collecting duct. Excuse me, collecting duct. Renal corpuscle leads to proximal convoluted tubule, leads to loop of Henle, leads to distal convoluted tubule, which then dumps into the collecting duct. That collecting duct will then lead down to the tip of the papillae and dump the urine into minor calyx, major calyx, renal pelvis, ureter. Okay? So that's the tubular system. Now the tricky thing is that along this tubular system, at different areas, different substances will be sucked out of the tube and sent back to the bloodstream. Okay? Different substances will be sucked out of this tube and sent back to the bloodstream. Well, how does that happen? If it's sucked out of the tube anywhere, and realize there's very specific areas that reabsorb very specific structures along this tube. I'm going to explain a few of them to you, but you don't need to know all of them. If you look in your book, there's a ton of them, okay? So, but in general, anything that comes out of this tube will be sent to, and this is 2 slides ahead of us, a series of what are called paratubular, peri meaning around, peritubular capillaries. So this network of capillaries sit around this tubular network just waiting for these substances to come out of the tubes. They suck them up and they send them back into the bloodstream. Okay? Why? Who cares? Who cares? This is why. If you become dehydrated, where do you want your water in your body to go? Do you want it to leave by your urine? Nope. You want to suck the water out of this tube. Specifically, it'll be right here in the collecting duct. That's one of the ones I want you to know. Water will come out of the tube, go into these peritubular capillaries and back into the bloodstream, and our body will reabsorb as much water as possible. Okay, sodium. You're getting low on sodium. Your body will reabsorb sodium. So we can retain water. So we can also have the action potentials happen. So your body's going to sense that it's getting low or too high with certain substances. It'll decide if we need to suck it out of these tubes and send it back to the bloodstream. If we don't need them, and we can secrete it out through the urine. Okay, that's why it's important. When kidneys fail, all these things can become imbalanced, and you can become very, very sick with kidney failure. Okay, so nephron, the microscopic filtration part of the kidney. Proximal convoluted tubule, we did. Loop of Henle, we did. Distal convoluted tubule is going to be very important in acid base. Okay, when you're talking about metabolic acidosis or alkalosis, it's primarily kidney. It's primarily kidney. The kidney will deal with 2 major ions, hydrogen, we're going to go over this in a few slides, and bicarbonate. Okay, bicarbonate is basic. Hydrogen ions are acidic. Okay, so the kidney will either get rid of or retain the ions it needs to balance our acid base. Okay. Collecting ducts. Collecting ducts are going to be this last one. Okay, this is the next slide, by the way, what a lung tube. Collecting duct is going to send urine out, but the collecting duct will also be a site of reabsorption of water. Okay, we'll get into that in a little bit. Afferent arterial we talked about brings blood into the renal corpuscle. Efferent leaves, okay, takes blood out. Peritubular capillaries surround the tubes. Vasorecta, don't worry about. It's actually a different form of peritubular capillaries. If you're interested, we're not going to get into that. As long as you understand peritubular capillary, I'm very happy with that. Okay, juxtaglomerular cells. So think for a minute. If we have blood flowing into this renal corpuscle, and part of the premise of creating this filtrate that will eventually turn into urine is that we've got to push substances out of that capillary. Okay, there's got to be a certain amount of pressure. I'm doing that on purpose. Okay, so pressure coming out of this capillary. If blood pressure drops, the pressure of blood coming into this is going to drop, and you're not going to push as many substances out into that capsular space. Okay. If blood pressure drops, we're going to have to raise it, and the kidneys are going to sense that. There are little cells that are located right in this area between the glomerulus, or those capillaries of the glomerulus, and the distal convoluted tubule. They both will sense a drop in pressure. They will release a hormone called renin, R-E-N-I-N. This is right in the notes. It's in your written notes. Renin does a series of very important things to raise blood pressure that we're going to go over in a little bit. Okay, renin's very important in helping to raise blood pressure. We raise blood pressure, we now have enough pressure to keep creating this filtrate. Okay? So we've got these series of cells that are between the glomerulus and the distal convoluted tubule. Juxtaglomerular, I forgot to mention, juxta means next to. If we compare or juxtapose something, we're looking at it compared to something else. Juxtaglomerular, next to the glomerulus. JG cells is what some people call them. Excuse me. Filtration. Now, of course, the capillaries that form the glomerulus are not going to be solid, right? If they were solid, there would be no filtration. Nothing would leak out of them. So what I'm going to do is erase all this gobbledygook. Okay. Now, if you imagine I take that tube, okay, that section of the glomerulus, I'm going to blow it up, okay? What it is a layer of simple squamous cells on the inside. And simple squamous cells are those egg-shaped cells, okay? They don't have a real definitive shape like cuboidal or columnar. And there's one layer of them lining these capillaries. Whoops. Okay, there's one layer of them lining these capillaries. Now this looks a little different from epithelia we've looked at before. Epithelia we've looked at before has been a nice solid line, hasn't it? This doesn't have a solid line. This has spaces, and those spaces are called fenestrations. Okay, those spaces are called fenestrations. So they're openings that things can leak through, okay? They're not huge openings though. Okay? Proteins should not leak through this area. If proteins leak through, there could be a disease process happening, okay? But fenestrations will allow substances to leak through. Now that's not the only line of filtration we have. If you can imagine that I take my hands and I have a tube and I wrap my hand around them and I interdigitate my hands, okay? I'm creating a bit of a barrier, but I still have some area that substances can leak through. There are cells called podocytes, P-O-D-O-C-Y-T-E-S, podocytes, which surround the glomerular capillaries, which create another line of filtration. Okay, so we have the fenestrated capillaries, then we have the podocytes around it. Then there's a layer of actually loose connective tissue on the outside of that. So blood and plasma proteins should not leak through. Blood cells, excuse me, red blood cells should stay in. Okay, blood cells will be seen though if we get an infection. Infection would spread up, cause inflammation, and open things up, wouldn't it? You'd have bigger openings that things could leak through. Okay, so kidney physiology, I'm just going to pause and restart the tape and erase the board. Okay, so if you want to take a little break, it's a good time to do it.